Welcome to another episode of Uncovering Bailey in Love with Snazzy Surgeon. You know, it's amazing to think how much our understanding of benign breast disease has evolved, even just in the last few years. I mean, I remember when we were all just throwing around terms like fibrosis and adenosis and epitheliosis like they were going out of style.
Oh, tell me about it. Fibroadenosis, fibrocystic disease. It was a real free-for-all. And Bailey and Love really drives home the point that all that confusing terminology wasn't doing us any favors.
Exactly. It made it so hard to communicate clearly, not only with each other, but more importantly with our patients. It's like we were all speaking different languages.
Precisely. Trying to have a meaningful discussion about diagnosis and management was, well, challenging to say the least.
Thank goodness for the ANDI concept, right?
Oh, absolutely. Aberrations of normal development and involution ANDI. What a game changer. That framework from the Cardiff Breast Clinic really helped to bring some much-needed order to the chaos.
It did. And what I really appreciate about NDI is that it shifts our perspective. It moves us away from seeing these benign conditions as completely separate entities and helps us understand them as part of a continuum, variations on the breast's normal response to hormonal fluctuations.
Exactly. It's all about recognizing that the breast is this dynamic, ever-changing organ, constantly responding to the ebb and flow of estrogen and progesterone.
So let's dive into Bailey and Love's take on ANDI, shall we? We'll break down the etiology, the hormonal influences at play, and then explore the spectrum of pathological changes we see.
Sounds good to me.
Now, the TDLU, the terminal duct lobular unit, is really at the heart of it all, isn't it?
It is. That's the functional unit of the breast where milk production happens. And it's incredibly sensitive to those cyclical hormonal changes we were talking about.
Right. Estrogen and progesterone basically act like growth factors, stimulating both the epithelial cells, which line the ducts and lobules, and the stromal cells, the supporting connective tissue within the TDLU.
And that's where the ANDI concept comes in. It recognizes that the pathogenesis of these benign conditions isn't about a sudden shift from normal to abnormal, but rather a continuum of changes in breast physiology.
A spectrum ranging from subtle variations that are practically normal to more pronounced deviations that we recognize as specific disease processes.
Right. It's not always black and white, and that's a crucial point.
It is. So with that in mind, Bailey and Love breaks down the pathology of ANDI according to the three key phases of breast development and involution.
Those being lobule development, cyclical changes, and finally, involution.
Exactly. Let's start with lobule development, which typically occurs between the ages of 15 and 25. What are we seeing happen in the breast tissue during this phase?
Well, this is a period of rapid growth and maturation. The lobules themselves are developing, the surrounding stroma is expanding, and the breast is essentially preparing for potential lactation.
And one of the clinical signs we often see during this phase is nipple eversion, right?
That's right.
Now, what about the so-called disorders, those deviations from normal development that we might encounter in our younger patients?
Well, the most common one we see is the fibroadenoma. You know, that classic, well-defined, mobile lump that's so reassuring on palpation.
Right, and of course we can't forget about adolescent hypertrophy, which can be really distressing for those young women.
Absolutely. It can cause significant physical discomfort and psychological distress.
And occasionally we might also see nipple inversion becoming apparent during this developmental phase.
Yes, that's true.
And then, unfortunately, there are the more serious diseases associated with this phase.
Yes, conditions like giant fibroadenoma, which can grow to be quite large, and gigantomastia, where we see excessive, sometimes debilitating breast enlargement.
And while not directly developmental in origin, inflammatory conditions like subareolar abscess and mammary duct fistula can also occur in this age group. So let's move on to the second phase. Cyclical changes, roughly spanning the ages of 15 to 50. This is where the breast's responsiveness to hormonal fluctuations really comes into play, doesn't it?
It does. This phase is all about the cyclical ebb and flow of breast tissue in response to the menstrual cycle. Many women will experience changes in breast density and tenderness throughout their cycle.
And of course, the epithelial hyperplasia we see during pregnancy is also a normal physiological response during this phase.
Precise.
Now, the disorders that fall within this cyclical phase are often what brings women to our clinics, wouldn't you say?
Oh, absolutely. Cyclical mastalgia, that breast pain that follows a monthly pattern, is incredibly common.
And then there's benign nodularity, that often bilateral feeling of lumpiness that can come and go with the cycle.
Right, and some patients will present with bloody nipple discharge during this time as well.
And for this phase, Bailey and Love lists incapacitating mastalgia as the disease. It's a good reminder that while most cyclical breast pain is manageable, there are women for whom it can be truly debilitating.
Yes, a very important point.
So, on to the final phase.
Hmm,
Involution, typically occurring between the ages of 35 and 55. This is where the breast undergoes those natural aging-related changes.
exactly.
What are some of the key histological changes we see during involution?
Well, we start to see a gradual atrophy or shrinkage of the lobules and ducts. There's often some degree of sclerosis, a hardening of the breast tissue as the stroma changes, and we also see a normal turnover of the epithelial cells lining the ducts and lobules.
And what are some of the disorders we might see during this involutional phase?
Macrocysts become more common as those smaller microcysts we talked about earlier start to join together, forming larger, palpable, fluid-filled sacs.
We can also see sclerosing lesions, duct ectasia, which is a widening of the milk ducts, and nipple retraction.
And of course, epithelial hyperplasia can also occur during this phase.
And the diseases associated with involution.
Periductal mastitis, an inflammatory condition of the ducts, and importantly, epithelial hyperplasia with atypia.
Ah, yes, atypia. That definitely raises a red flag.
It does. That finding warrants careful evaluation and follow-up because of the increased risk of future breast cancer.
So let's unpack some of these key pathological features a bit further, starting with hyperplasia of the epithelium. What's the histological definition that's so crucial for us to understand?
Basically, hyperplasia in this context means we're seeing more than 2 layers of epithelial cells lining the ducts and acini. And this increase in cell layers can happen without any atypia, meaning the cells themselves look normal under the microscope, or it can occur with atypia, meaning the cells have some abnormal features.
And that distinction, the presence or absence of atypia, is really what guides our management, isn't it?
Absolutely.
Bailey and Love specifically mentions atypical ductal hyperplasia, or ADH, and atypical lobular hyperplasia, or ALH. Can you remind us what's particularly important about ADH in terms of diagnosis?
Well, if we find ADH that involves more than 2 ducts, or if the lesion is larger than 2 millimeters, it actually meets the criteria for ductal carcinoma in situ, or DCIS.
So that 2 millimeter threshold is key.
It is.
Okay, let's move on to papilloma. Can you describe what that looks like histologically?
Sure. A papilloma is essentially a localized overgrowth of the ductal epithelium. It forms this little, often frond-like structure within the duct. It has a central fibrovascular core, kind of like a stalk. And from that core, you see these numerous papillary projections made up of both epithelial and myoepithelial cells.
And there are different types of papillary lesions, each with its own associated risk of malignancy.
Right.
Let's start with the solitary papilloma, which we usually find in the larger ducts. What's the relative risk of breast cancer associated with this type of lesion?
Typically, a solitary papilloma carries a relative risk of about 1.5 to 2. So it does slightly increase a woman's risk compared to the general population, even though it's considered a benign lesion.
What about papillomatosis? How does that differ?
Papillomatosis means we're seeing 5 or more papillomas, and they're usually in multiple ducts. They tend to be located more proliferally in the breast tissue and are often found in both breasts.
And the risk associated with papillomatosis?
It's higher. The relative risk of breast cancer in women with papillomatosis is about 3.
Okay. And then there's juvenile papillomatosis, sometimes called Swiss cheese disease. It has some unique features, doesn't it?
It does. This one typically affects younger women and often presents as multiple firm nodules that you can feel on exam.
And histologically?
Microscopically, it can be quite complex. You'll see multiple papillomas, some of which might show atypia, along with apocrine cysts, ductal hyperplasia, and sclerosing adenosis.
And a family history of breast cancer is a big risk factor for these patients, right?
Yes, definitely. If a patient with juvenile papillomatosis has a family history of breast cancer, her lifetime risk of developing the disease is significantly increased.
That's really important information to keep in mind when we're counseling these younger women. Okay, last but not least, cyst formation. How do these cysts develop?
The thinking is that cysts form when the terminal ductules get kinked or narrowed, often as part of the normal involution process.
So those aging-related changes in the breast tissue can actually contribute to cyst development.
Exactly. This partial obstruction can lead to a buildup of fluid in the lobules, initially forming tiny little microcysts. And over time, those microcysts can merge to form the larger, palpable macrocysts that we can feel on exam.
So we've covered the key pathological features of ANDI, but what about the clinical presentation? How do these benign breast conditions typically manifest in our patients?
Well, the most common presenting complaints are breast pain or mastalgia, benign nodularity, which is often described as a lumpy or bumpy feeling in the breast, and the presence of discrete lumps.
Let's start with mastalgia. What clues might suggest that a woman's breast pain is related to those cyclical hormonal changes we've been talking about?
The key feature of cyclical mastalgia is that it follows a predictable pattern linked to the menstrual cycle. It often starts around day 14 of the cycle, coinciding with ovulation. Then the pain gradually gets worse, reaching its peak in the days leading up to her period.
So that premenstrual exacerbation is a classic sign.
It is.
Now, what about benign nodularity? What are some typical findings we might note on physical exam?
Benign nodularity can be localized to a specific area of the breast, or it can be more diffuse, affecting larger areas and often both breasts. We often see it most prominently in the upper outer quadrant.
And like cyclical mastalgia, this nodularity can also fluctuate with the menstrual cycle.
Right. It often becomes more noticeable in the week or two before a woman's period and then tends to improve once her period starts.
And lastly, discrete lumps. Is there a correlation between a woman's age and the type of benign lesion we might find?
There is. In younger women, say in their late teens and 20s, a discrete lump is most likely to be a fibroadenoma. As women get older, particularly once they hit their 40s and 50s, cysts become a more frequent finding.
So to wrap things up, the ANDI classification really gives us a more logical and clinically useful way to understand these benign breast conditions. It's much more informative than those vague, overlapping terms we used to use.
I completely agree. By focusing on the normal developmental, cyclical, and involutional changes of the breast, we can better categorize these aberrations and tailor our management accordingly.
It also helps us communicate more effectively with our patients, which is so important.
Absolutely. It allows us to explain what's going on in a way that makes sense and helps them feel more confident in their care.
And ultimately, that's what it's all about.
It is.
Thank you for listening to our podcast. See you in the next episode.